Hello, and thanks for listening to the MiCare Champion Cast. In our last episode, you heard the value that Medicaid brings to patients across the state and why we need to protect a program that is saving lives and keeping vital healthcare services online. Today's episode will focus on a very specific issue impacting patients covered by Medicaid who are seeking behavioral healthcare services in hospital emergency departments. More specifically, we'll learn about unnecessary hurdles in the process and what can be done to ensure a more straightforward and seamless journey to getting inpatient behavioral health care. Joining me in studio to help guide the conversation, I have my colleague, LaPine, who is our Senior Director of Legislative and Public Policy here at the MHA. Lauren, thanks so much for being here.
Happy to do it.
How has life been treating you?
It's so good. At least the sun is out and it's a good day.
Very true. Well, I gave a little bit of an intro about what we're going to be talking about today, but can you just kick things off by giving us a picture of how many patients are seeking behavioral health care services in our hospital emergency departments?
Yep, happy to. The MHA last year, actually for about a year and a half, collected data from our hospitals and health systems across the state and asked them specifically how many patients are stuck in the emergency department across the state that are waiting for behavioral health services. And we know from that survey, as well as from some inpatient data that we collect, that there are more than 150 behavioral health patients, including an average of 17 children every day that are waiting in emergency departments due to a lack of available inpatient psychiatric beds across the state or due to the fact that they are waiting for the necessary assessment to determine what type of behavioral health treatment they need. So over 150 patients are really stuck in emergency departments across the state on any given day, anywhere across our state.
Anecdotally, when you talk to our members about this, what are they saying? I know you work really closely on some of our behavioral health efforts at the association. What are you hearing from members just knowing that it's affecting hospitals of all sizes across the state?
Yeah, we hear from our members, I would say on a weekly basis, that reach out that have a challenging case with a patient that's stuck in their emergency department. And many times what we're hearing from hospital leaders across the state is that they are struggling to get the necessary staff to come in and provide the requisite screening for a patient that needs behavioral health services, or they are struggling really hard to find an available inpatient psychiatric bed across the state of Michigan. And many times when we hear from these hospital leaders and clinicians, they're really coming to us as a last resort because they've tried so many different avenues and advocated in a variety of ways on behalf of the needs of a patient and their family, and they're stuck in trying to navigate our pretty complex behavioral health system. And so they come to us and they ask us for our help. And we try to make connections as we're able to, because many times the patients that are stuck in EDs have been there for honestly weeks, if not months. And no one wants to really go to an emergency department. It's not designed to be a fun place to go.
Right.
And many times these folks that need behavioral health services are stuck there for an extended period of time.
Right. So can you walk us through what the experience of a commercially insured psychiatric patient who's walking through the ED, what does that look like for them?
Yeah, happy to do so. And the interesting thing in Michigan is that we have in our statute, we've designed the process for receiving behavioral health services in a pretty different way, depending on if you have commercial insurance or if you are a Medicaid beneficiary. So say I go into the emergency department and I am commercially insured and I present to the ED in some type of behavioral health crisis. So most of the time I'm going to show up, I'm going to go to the emergency department, and I'm going to be assessed by the team of clinicians and likely an emergency room physician at a minimum. And that physician and clinician team is going to determine what type of behavioral health services I need, whether I need inpatient psychiatric care and a facility somewhere across the state to receive that care, or if I need some level of outpatient community-based care. Once they've completed that assessment in terms of what I need from a clinical perspective, then they're able to either find me an inpatient psychiatric bed across the state and help me be transferred to that facility, or they can set me up in an outpatient setting with the type of behavioral health services that I need there. And what we see in our data is that those patients that are commercially insured tend to move through that process notably more quickly than those that are a Medicaid beneficiary. If you are a Medicaid beneficiary, on average, you're waiting more than 33 hours in the emergency department to receive the necessary behavioral health care that you need, compared to if you're commercially insured, you are waiting 27 hours, which is still a long period of time, but that's a pretty notable difference in the amount of time that you're spending in the emergency department that's really predicated on your insurance type.
Right, yeah. So tell us what the experience often looks like for a patient who's covered by Medicaid.
Yeah, so for a Medicaid patient that needs the same level of psychiatric care as the example that I just walked through, there are often a series of hurdles which can take several hours, if not days, for the patient and the care team to overcome before the individual is able to be placed in an inpatient psychiatric bed within our state. And one thing that I think is important to call out in this space is that in Michigan, in state law, the community mental health agencies are required to complete a pre-admission screening for inpatient psychiatric stays within 3 hours of being notified by a hospital or health system across the state. And one of the things that we are seeing from our data and that we're hearing from our members is that those assessments do not happen routinely within that 3-hour time frame. So our data tells us that currently 1 out of every 3 patients that uses Medicaid will spend more than 48 hours waiting in the emergency department. And that is a different statistic compared to those that have commercial insurance. So for this specific example with this patient, we'll say the patient walks into the emergency department. Before they are even given an assessment, the patient is required to show some kind of documentation of the county that they live in. And this is a really important piece because if I live in Ingham County and I show up to the we'll say the Michigan Medicine Emergency Department in Washtenaw County, Michigan Medicine is required by law to work with the Ingham County Community Mental Health Agency. So you have to be able to show your proof of the county in which you reside, and then it's incumbent upon the hospital to work with that county-based community mental health agency. And something that I think is important to call out is if we were comparing this to someone that was experiencing a medical emergency, if you're having a heart attack, you're not immediately going to think, you know what, let me grab my driver's license or let me grab my passport and bring that into the emergency department. If you are seeking emergency care, whether that be for a medical need or a behavioral health need, you're not necessarily thinking to grab all of your necessary documentation. So this added step for patients that are using Medicaid adds another hurdle and can result in a longer wait time in the emergency department. So going back to that process, once the patient is assessed by the emergency room clinicians and the ED physician and many times a psychiatrist, depending on the size of the hospital, then the hospital calls that local community mental health agency and asks the CMH agency to come in and complete a pre-admission screening. And this is required by law for Medicaid beneficiaries to receive that pre-admission screening from a community mental health agency. And this is really where the timing often varies based on how long it takes for a community mental health agency team to respond to the hospital, or if someone is even available to screen the patient in person or virtually. So we do have some facilities, some hospitals across the state that have agreements with their local community mental health agency where they have the bachelor's level social workers embedded in the ER. So it's quicker for them to provide that assessment. But we also have some CMHs across the state that do not provide that 24/7 in-person assessment, but instead do things virtually via an iPad or even sometimes over a phone, via a phone call.
And you've heard from members that in some cases, patients are coming to the ED on a Friday, and if a community mental health agency is closed for the weekend, that has them waiting for days for that care.
Yeah, one of the things that it's easy to forget is that a hospital is open 24/7, 365 days, whereas many community mental health agencies are closed on the weekends or limit the amount of time that they have folks in office to provide those pre-assessment screenings. So we hear routinely from hospitals that place a call to their local CMH on a Friday at 4 and don't hear back from that CMH until Monday at 9 a.m. when they're able to check the voicemail. So again, that patient has been sitting in the emergency department for the entire weekend waiting for that assessment to be completed.
Right. So then following the second pre-admission screening from the CMH, what happens from there?
Yeah, so once the CMH completes that assessment, that's really what indicates the next level of care that the patient will receive, because it's important to point out that the prepaid inpatient health plan that corresponds with each of the community mental health agencies across the state, those are the payers for the public behavioral health care system. So they are many times unwilling to pay for an inpatient psych stay if a CMH has not authorized it via that pre-admission screening. So once the screening has happened, if the clinicians in the ED and the clinicians from the CMH agree that a patient needs inpatient psych care, then the CMH will help find the inpatient psych bed across the state. And the entire time that process is happening, which I don't want to discount, is an arduous process to find a bed, that patient is still sitting in the ED waiting for the CMH to find the assessment or to find the available bed. The thing that I think is key to point out in the comparison of these two processes is there are a whole slew of additional steps that must be completed if you are involved in the public behavioral health system than if you are commercially insured. And what we are seeing in our data is that equates to longer wait times for patients in the emergency department and more challenges in terms of accessing inpatient psychiatric care across the state. And we're concerned about what we're seeing in our data, and we're also concerned about what we're hearing from our hospitals. I very rarely am ever contacted by a hospital that is experiencing a challenge finding placement or getting an assessment for someone that has commercial insurance. They are always from examples where the patient is a Medicaid beneficiary and is statutorily required to work with the public behavioral health system in Michigan.
And I think it's worth noting that you've heard from some of our member hospitals that this process is lengthy for any individual, but especially for pediatric patients.
Yeah, that's a really good point. And we do have data at the association that tells us that the two groups that are boarding, that are waiting the longest periods of time in EDs across the state are those that are children and those that are in the geriatric population. And I think it's important to point out that those are both populations that require an additional layer of specialized training and education from a healthcare clinician standpoint. But we also know that children in particular with intellectual and developmental disabilities, those cases are also boarding for the longest period of time in the emergency department across the state, which is why we're hoping to see some changes in this space to really expedite that process and try to get patients into the care that they need as soon as possible without having these relatively arbitrary barriers.
And I can only imagine the mental and physical toll that that's taking on patients who oftentimes need life-saving psychiatric care. What else are you hearing from hospitals in terms of how it's affecting the overall operation of an emergency department?
Yeah, there's a couple of ways to answer that question. So the first is that we are hearing routinely about increases in the instances of healthcare workplace violence that are occurring across the state. And that's not to say that only behavioral health patients act out and can be violent against their caregivers. That's not at all the case. But what we are seeing is that humans are humans. If you are stuck living in a small room for weeks, if not months on end, you're not your best version of yourself, and that can lead to increased agitation. So we are concerned about the rising instance of workplace violence that's occurring in hospital emergency departments across the state. We also are worried about the capacity challenges and gaps that we continue to see. I'll always remember I went and toured a hospital emergency department, a large hospital emergency department last year, and they were seeing such an increase in the number of behavioral health patients that were coming to their ED that in order to keep them safe, they had to convert a number of their rooms to be anti-ligature rooms and to make sure that there was nothing that would put the patient at risk.
Wow.
And in doing that, they were decreasing the capacity for the number of patients that they could take that might come in that had a car accident or had some other level of trauma.
Wow.
But really, folks are coming to emergency departments across the state in crisis, whether that be a behavioral health or medical crises, and our members are really having to think strategically and pivot their physical infrastructure space to meet the rising needs for behavioral health care.
Right. So what is a possible solution to this, and what would it look like?
Yeah, so there's a number of solutions in this space, but one that we are advocating for at the association is we, alongside many of our member hospitals, are recommending that we expand the 3-hour assessment responsibility that I talked through previously in the kind of process for receiving behavioral health care. We would like to expand that to allow for clinically qualified staff to conduct pre-admission screenings. And we want to do that because we think that will improve the delivery of care for behavioral health patients in Michigan hospital emergency departments. So one of the things that I didn't mention earlier was that hospitals are staffed in a variety of ways, but hospitals routinely employ master's level social workers, as well as registered nurses, ED physicians, and psychiatrists. And so emergency departments across the state are well equipped to complete that pre-admission screening to determine if someone needs inpatient psychiatric care. Many community mental health agencies across the state are employing bachelor's trained social workers, and those are the ones that are deployed to go and complete those pre-admission screenings. And so we really think that that hospitals are well equipped to have the necessary staff that are well trained to complete those assessments. Because at the end of the day, a qualified clinician should be able to determine whether someone needs inpatient psychiatric care or whether they do not. So really what we would be suggesting is adding an additional workforce to do those types of assessments, recognizing that we have significant behavioral health workforce shortages across the state.
Right.
And this would be a way to take some of the pressure off of the public behavioral health system and allow our hospitals with qualified clinicians to also complete those assessments and help when there's a bottleneck, when a CMH cannot get there within 3 hours to assess the patient.
And I think it's important to say explicitly in this conversation, and as you talk about a solution, that this is not about pitting providers against providers. Obviously, hospitals and community mental health agencies all play a very important role in the overall behavioral health ecosystem. It's just about simplifying the process because they do all share the goal of getting these patients the care they need when they need it.
Absolutely. And that's why at the association, we think that implementing this change will really help us to expand the number of available healthcare personnel that are able and available to conduct those assessments in that first 3 hours of a patient presenting to an emergency department. The other thing to kind of bring it full circle is that it also allows Medicaid patients to be assessed in a similar manner as patients that have commercial insurance.
Right.
And we feel very, very passionate about making that change.
Well, Lauren, I just want to thank you so much for being here today. I'm so grateful for your time and your insight on this issue. I know we have an informational hearing coming up next week, and we're also going to have a lot more information on our website in the days and weeks to come. But any final thoughts that you would give our listeners?
No, nothing really additional to add at this time, other than you already alluded to it. But the MHA on our website, we do have a tab related to behavioral health, and we have some data that I alluded to today, as well as kind of an infographic that describes some of our main concerns. And so that is publicly available, and we are always encouraging folks to go look at that and also provide us feedback on how we're approaching this. So thanks for the time.
With that, I'd like to thank our listeners for tuning in and encourage you head to MHA.org to learn more.